So we now start on chlamydia. So chlamydia, the family is called Chlamydiaceae. The most important species that I want you to know is Chlamydia trachomatis. That is the most important one. Then we have Chlamydiophilia pneumoniae, Chlamydiophilia psittaci. Okay. But the most important here you should know is Chlamydia trachomatis. But we're going to go through all the three. Now, this is the characteristics of chlamydia. Small obligate intracellular parasites. Should be bacteria, that is. So if it is obligate intracellular, you will not be able to gram stain it because it is obligate intracellular. We use GEMSA. Contains DNA, RNA, and ribosome and make their own proteins and nucleic acid, unable to make their own ATP. Okay. Have a special growth cycle and replicate by binary fission. Possess a rigid cell wall similar to gram-negative bacteria and are sensitive to antibiotics. Respond to wide spectrum antibiotics, but do not to penicillin because they don't have the peptidoglycan layer. Okay. We start with the special growth cycle. So this is very high yield. You should know this. The elementary bodies and the reticulate bodies. Now, let's start with the elementary bodies. For the elementary bodies, these are small, 0.3 to 4 micrometers, infectious form. So this is the infectious form. Can you see this? So it has a rigid outer membrane. And since it is an infectious form, it has to be resistant to harsh environmental condition outside of eukaryotic host cells. They bind to receptors on host cells and initiate the infection. So remember that the elementary body is the infectious form. So it has to be resistant to this harsh environment. But now for the reticulate bodies or the initial body, it is the non-infectious form and it is intracellular. It is the one that is going to be metabolically active and able to replicate. You see, does it make sense? Because you see this one, this is yet to infect the host cell. So it has to be harsh and resistant. But for this, it has already entered the host cell. It is an intracellular form and it is metabolically active so that it is able to proliferate and divide and give rise to more chlamydia species. Okay, have a fragile membrane and easily broken because it is intracellular. Okay, so this is the process of how it starts. You see, we have the elementary bodies, attachment, ingestion. Then there's the phagosome fusion, reorganization of elementary bodies to the reticulate bodies, and then multiplication, condensation, mature, then it bursts, then it repeats the cycle. Okay. Most important thing, you know, elementary bodies are the infectious form. Reticulate bodies are the metabolically active form that is going to replicate inside the host. Okay. So elementary bodies, infectious, enters the cell. So that is E via endocytosis. Reticulate bodies replicates by fission, and then it reorganizes to elementary bodies. Okay. Elementary bodies are metabolically inert or inactive. Reticulate bodies are metabolically active. Clear? Then here are the chlamydia inclusion bodies. And you see inside of the cell, these are the reticulate bodies. So this was a good summary because this can come in an essay where you're told to compare elementary bodies to reticulate bodies. Elementary, remember, are the infectious, so they have to be rigid, they're infectious in nature, relatively inactive metabolically, resistant to trypsin digestion. Remember, trypsin is an enzyme that is secreted by the pancreas to digest normally protein. Okay. Projections, very few. And then this one is fragile because it's found inside it's intracellular, non-infectious. RNA to DNA increased, then it is actively metabolically because it is replicating. Then trypsin digestion, this one is not resistant. Okay. So this is a very important point you have to remember. Now let's start. So that was the whole of chlamydia. Now we go to specific. Chlamydia trachomatis. So when you hear people mention about chlamydia, this is the chlamydia we're talking about. The chlamydia trachomatis. Okay. Ignore this story of biovars. What I want you to know is there are serotypes. Serotypes, yes. Okay. Before I mention the serotypes, here's the pathogenesis and the immunity. It usually infects non-ciliated columnar cells. So first of all, you have to know, before you describe the pathogenesis, where is it going to infect? So there are different chlamydia trachomatis serotypes. Some will go to the eyes, some will go to the reproductive system, some go to the lymph nodes, okay? But the pathogenesis is the same. It infects non-ciliated columnar epithelial cells, stimulates the infiltration of polymorphonuclear cells and lymphocytes. So these polymorphonuclear cells are basically neutrophils, which lead to lymphoid follicular formation and fibrotic changes. This is going to lead to cell destruction and inflammatory response by the host. So the fevers and all those. The infection does not stimulate long-lasting immunity. Reinfection results in an inflammatory response and subsequent tissue damage. Okay. So before we mention the treatment, I'm going to come back here. Here are the serotypes that I was talking about. So we have A to C. So this is A, B, and C. D to K. Then serotype L1, L2, and L3. Now this is very easy. A to C, how I used to remember it is ABC, Africa, blindness, chronic infection. Why am I saying that? It causes something known as trachoma. So what is a trachoma? A trachoma, let's see our picture here. Here it is. This is a trachoma. Okay. A trachoma is caused by this chlamydia species. And what is happening here is you're going to have an infection. And this infection is going to be caused repeatedly. Okay. Now, this repeated infection of the eye, as you can see here, is what is going to cause the scarring, normally of the inner eyelid. Can you see this inner eyelid? Within the inner eyelid. It's going to cause scarring. And then this scarring is going to spread, leading to corneal scarring. You know, cornea is the outer layer of the eye. So it's going to cause scarring. Now, this repeated infection leading to scarring is going to cause blindness. Why I said Africa? Because it is the most common cause of blindness. Mainly seen in Africa, because how is this disease transmitted? It is transmitted by improper or poor sanitation. Okay, so what happens is flies, don't know if you've ever seen flies, the flies carry this chlamydia, go and drop it in your eyes, you don't wash your hands. So poor sanitation, you don't wash your hands, you don't wash your face, and that's how the trachoma gets to the eyes. Okay, and it's a very specific serotype, which is A to C. So you remember Africa, blindness, and chronic infection. Then serotype D to K. D2K causes urethritis, cervicitis, inclusion conjunctivitis, neonatal conjunctivitis, infant pneumonia. So let me start with L1 to L3 before I do DTK. L1 to L3 causes something known as lymphogranuloma venereum. So you're going to ask yourself, what is that? Lymphogranuloma venereum is ulcers on the genitals. So let me skip that first. Yeah. This is the STI, a chronic sexually transmitted disease caused by Chlamydia trachomatis, L1, L2, L2A, LT3. Okay. How does it present? Buboes. Where have you had buboes before? Who remembers? Have you heard the term buboes before? So buboes, you heard it when you were talking about Yersinia. Okay. Buboes. So what are these buboes? Buboes are the swellings of the regional lymph nodes, especially the inguinal lymph nodes. Okay. And they are very, very painful because it's an infection. So it's going to be very, very painful. Okay. More common in men, with male homosexuals being the major reservoir. Small painless lesions at the site of infections, the genitalia, and then the constitutional symptoms, fever, headache, myalgia. Proctitis is common in women. The proctitis is inflammation of the rectum. Resolves spontaneously or progresses to ulceration or genital elephantiasis. Okay. So how do you treat this? You just give doxycycline and we drain these buboes. Okay. Now, why I started with this? Because the other causes of, chlamydia, the serotypes, D to K causes the rest. So A causes the blindness, L1 to L3 causes lymphogranuloma venereum. Okay. Now, what are these? Urethritis, cervicitis, inclusion conjunctivitis, neonatal conjunctivitis, and infant pneumonia. Okay. Now, let's see. So for the trachoma, maybe sorry to mention, worldwide, primarily in areas of poverty and overcrowding, 500 million people are infected worldwide. 7 to 9 million are blind as a consequence. Infection occurs mostly in children. The organism can be transmitted by droplets, hands, contaminated clothing, flies, and passage through an infected birth canal. That is for the trachoma, as I had mentioned. Then now for the other serotypes, D2K, urogenital infections. Most common sexually transmitted bacterial disease in the US, 2.8 new cases annually, largely in males. Females, 80% are asymptomatic, but it can also cause patholinitis, cervicitis, PID. Remember PID? The most common causes of PID is the chlamydia and Neisseria. Okay. And then we have, which can lead to sterility and ectopic pregnancy. And then we have, in men, 25% asymptomatic non-gonococcal urethritis. Okay. So if you're to differentiate between this and gonorrhea, gonorrhea is severe, acute, severe dysuria, purulent discharge. For non-gonococcal urethritis, mild pain, slow and prolonged, dysuria is mild, urethral discharge is clear or white or thin and mucoid. Okay. For the non-gonococcal urethritis, you see, gonorrhea is the most common cause of urethritis. Then the rest are called non-gonococcal. The most common ones, as I had mentioned, Chlamydia trachomatis, Ureaplasmin urealyticum, Mycoplasma hominis. There are others, Gardnerella vaginalis, Trichomonas vaginalis, Candida albicans. This is a fungus. Okay. herpes, and CMV. These ones are still under research. Okay. Then adult inclusion conjunctivitis. So conjunctivitis, so you know that is affecting the eyes. Acute follicular conjunctivitis with mucopurulent discharge. Mostly occur in sexually active adults with genital infection in serotype A, B, D to K. Okay. Autoinoculation. So this is autoinfection, and oral genital contact leads to this conjunctivitis. Newborn. So for newborn, you're going to see a child who has some pus or purulent discharge on the eyes. If you ask the two bacteria, it is Chlamydia trachomatis, serotype D2K, and gonorrhea, Neisseria gonorrhea. 25% of infants acquired from mothers with active genital infection, long disease course if untreated, and a risk of Chlamydia trachomatis pneumonia. That is here. So what is specific about this pneumonia is we have something known as the staccato cough. Okay. And it is afebrile. So afebrile means that there won't be fever associated with it. Okay, so rhinitis leading to a staccato cough, which is afebrile. It is mostly marked by eosinophilia. And we know that eosinophils deal with allergic reactions and things like that. Okay. And it's an interstitial pneumonia. So interstitial means that it's affecting the interstitium layer. Okay. Then this was, so these are the inclusion bodies, iodine stained for chlamydia. Chlamydia urethritis, elementary bodies, indirect smear of urethral cell, fluorescent antibody staining. Okay, can you see them? So this is before they enter the cells. Okay. Okay. So for lab diagnosis, cytology, examining stained cell scrapings of for the presence of inclusion bodies. Culture, the iodine staining inclusion bodies, as we had seen. And then culture of susceptible cells, the most specific method for diagnosis. Then serology, we're going to see if IgG and IgM antibodies is indicative of a recent infection. So we know IgG is chronic infection. Okay, now that is Chlamydia trachomatis, we are done. We now go to pneumophilia, Chlamydophilia pneumoniae, and Chlamydiaphilia psittaci. So for pneumoniae, in fact, both pneumoniae and psittaci are a cause of pneumonia. Okay, and it is atypical pneumonia. Why is it atypical? Because it presents with a dry cough and low-grade fever. So it was first isolated from the conjunctiva of a child in Taiwan using the TWAR stain, an important cause of bronchitis, pneumonia, and sinusitis. Infection is common, especially in adults, and transmitted from person to person by respiratory secretion. So when you cough, respiratory droplets, we usually call it aerosol transmission. Okay. Clinical disease, it is an atypical pneumonia. Most infections are symptomatic or mild. There is a persistent cough. So these are the other types. You see Legionella pneumophilia, M. pneumoniae, and other respiratory viruses, because they don't cause the typical pneumonia with the sputum. So it's detected in atherosclerotic lesions in blood vessels. However, the role in development of atherosclerosis is not clear. But this is just good to know. Okay. Lab diagnosis. Diagnosis is difficult. Normally we use PCR. Okay. Do not grow in cell lines. NATs are okay for use. So what is NAT? Nucleic acid amplification testing. Okay. Complement fixation test, not specific, or MIF specific. So NAT. So we usually use PCR and NAT, and then definitely cytoplasmic inclusion bodies when we are doing a GM sustain. Okay. And then before I go to the drug of choice here, we use azithromycin. Remember, when we were treating gonorrhea, we give azithromycin. You see, for gonorrhea, we were treating with ceftriaxone. Then we add azithromycin to cover the chlamydia. Okay, so azithromycin is a macrolide. It's used. In this case, you cannot use a penicillin or a cephalosporin because this one doesn't have a cell wall. Okay. Okay, that is how we treat it. Clear?